the last scientific session, pattern of canalicular lacerations with LITER, clinical profile and surgical modalities. Chief and presenting author, Dr. Shreya Shah. The co-authors, Ashit, Gemini, Pandya, Mehul.
Good morning to dignitaries sitting on dais, and I'm grateful to you for allowing me to present this. I'm going to present the patterns of canalicular laceration with lead laceration, clinical profile and surgical modalities, and most of the demographic details. Canalicular lacerations are common injuries of the canalicular system. The key step during the surgery for the treatment of canalicular laceration is to identify the severe cut end of the canaliculus, and on basis of canalicular anatomy and microscopic magnification, locating the damaged end is most important. Different surgical procedures such as so many mini monoca discussed in previous session also, so many surgical techniques are available nowadays. And if we are able to put stent during that, it prevents the passage. The aim to evaluate the demographic and epidemiological data of eyelid lacerations with or without canalicular injury, and we prospectively collected data from all the patients attended our outpatient department from 2010 to 2015, and data was collected in pre-tested format. Statistical analysis was done. All cases who were repaired were included. We documented all informations including demographic data, information regarding injuries and post-operative information. We recorded data in the pre-tested online format. We exported data and analyzed using SPSS 22. We obtained permission from our hospital ethical committee, and we found these results. 91 patients evaluated for eyelid laceration. Majority were from the age group 1 to 10, and mostly 86 from the lower socioeconomic, 86% from lower socioeconomic group. Male preponderance was there. Right eye was the majority of the patient, and 37.5% had upper lid, lower lid, and 27% associated canalicular tear. And these are the distributions of population in accordance with the diagnosis what we found in our study, and majority of their were having canalicular lacerations along with the things, and the cause of the study, majority of them were a road traffic accident. And various surgeries we have performed in all our series, including canaliculostomy and varieties of the intubation techniques. Lacrimal system injuries usually occur, and we have to have lots of material available if a patient comes in your clinic in emergency. The main cause is what we found: dog bites in children, and suffices young and adults, and falls in the elderly patients. Although the canalicular injuries are relatively common, controversies persist regarding the repair and the surgical methods to be employed. Method of treating canalicular laceration include extrusion or anastomosis with the placement of canalicular stent. Canalicular stent may be placed with the monocular, canalicular, bicanalicular, annular, or nasal fixation techniques. Mini monoca and Teflon, as discussed by previous speaker, also available, but it has got its own advantage and disadvantage. We can use Prolene suture also, and this is the little different way we started. The most important point when we are not able to find the severe end of the canaliculus when we get the patient. So this is the very simple and easy technique devised on the pigtail prop which is available. So we took 40 Prolene suture, and the cut end of the same needle we just made it blunt by cutting the end, and then the same thing we pass through the upper canaliculus. We can try all other methods to find out the cut end of the lacerated other end of the cut canaliculus, including saline irrigation and fluorescein pattern. But this we found very easy. It finds the other end, as well as the same Prolene we can use as a stent. So we just pass from the upper canaliculus and just trace and don't push. If you push, you can get the false passage. So once it is out of the other part, we can just So this is the way it is coming out, and then again we can tie with the other cut end of the lead, and the success rate we have found, we have done in few patients, and it's working very well. So this is the way second part is taken out. So, and in my conclusion, lead injuries are common in upper lead. 53% in our study had a upper lead, seen commonly in males, road traffic accident being a most commonest cause, 28% in our study. Incidence of canalicular damage was high in 27.5%. And we have to be aware about the secondary epiphora after repairing of the primary. So there are many causes for the secondary epiphora which can be immediate and late, and difference between hyperlacrimation and epiphora also you need to take care, like our previous speakers spoken about the Teflon sleeve, and sometime by canalicular intubation there will not be epiphora, but when the Teflon sleeve is put, it's touching to the cornea and it can give. We have done, this is Prolene spleen technique, so that was a complete avulsion of the lead, and then we just passed the Prolene suture from the tarsal plate, tied on both the sides with the bone periosteum, and the results were very good. Thank you.
Thank you, Dr. Shah.
Thank you, madam. Now, how did you identify in severe lead laceration cases? It is very difficult to identify the cut end because of elasticity of the lead. And how did you identify in those cases? Have you used any stains, or what is the role of pigtail probe in your cases? There are so many, 91 cases are there.
Yeah, so we have tried. We have done all the, we have tried all the modalities, including fluorescein pattern, saline technique, mini monoca, but most important thing is while we pass the pigtail probe has its very thick probe, and most of the time we have seen that it damages the normal canaliculus. So according to that design we have done this is simple, a 4-0 Prolene needle, and the curve of the 4-0 Prolene needle, that's 3/8 circle, which is exactly matching with pigtail. So we have to make is a pigtail vertical.
One canaliculus is preserved, another punctum is preserved, another is lacerated. In both the punctal laceration,
yeah, if both the punctum laceration, then we usually prefer bicanalicular intubation.
Pediatric pigtail probes are available, and double curve, single curve probes are also available. It is very, very helpful to use.
So both the punctum, if we have, we try bicanalicular intubation.
Retracted punctum can be highly visualized easily under high magnification by its a corrugated appearance, just like a mucous membrane intestine cut, and there is a flower-like pattern of the punctum can be easily recognized.
Yeah, that's the ring reflex. Thank you, sir.
Yeah, the smooth round-tipped pigtail probes are also available, which are very easy to pass. Yeah. Any question from the audience? We have 2-3 minutes left. Yeah.
Extensive lead lacerations, is there any role of a graft been used?
Which graft?
I mean, post-auricular, if you have got basically a very extensive lacerations, just cover that area, you could not basically do it with the skin. There will be a big gap. So in some of the cases, they usually use a post-auricular graft also to cover that dent.
Dr. Shreya, you would like to answer his question? He is asking.
Can be done in the cases of massive lead lacerations.
Yeah, we usually prefer the post-auricular graft, and that's very best because the skin is matching there. And along with the graft, in our series we have tried when there is a full avulsion of lead and you are not able to take the graft, and sometimes if it is lower lead, it sags. So ectropion will develop. So what we do that, through and through that graft, we pass the Prolene suture, passing through the periosteum, taking it back, again passing to the periosteum, which preserves the anatomy. and it preserves. But then Tytler syndrome can be there, so we have to be balanced.
Basically, this was done long back. We have got an injury which is called as a handpeck injury. Domestic birds like pigeon, parrot, and this cock. In villages, when the children are in the vicinity of these domestic birds, one lead was eaten away by that hen. In that particular case, this was done.
So
Okay, thank
what
you.
we